All right, good afternoon, everyone. Welcome. This is Travis. I get to host this week since Jeff is away. Hopefully, Howard, will be back soon. Seth, you want to start? I think it's going to be mostly you and me.
Sure. Did you send me I didn't get an invite. There it is.
You should have gotten it. Yeah.
I just got it. Okay. Yeah, nothing too interesting. This is a patient who had repeated episodes of shortness of breath. Even knowing where it is, I don't know. It's kind of hard to call. I mean, does anyone see anything on this? Let me try to pull up the lateral. Maybe you can see on the lateral better. Nope, no, that's not going to work. You can't see it on lateral. You can barely see on the frontal. Anyone see anything at all?
Not yet.
Anyways, I don't even know if it's real, but there's something there.
Oh, yeah.
I mean, I was trying to equate it to what it actually turned out to be. I'm still not sure that's actually what it was, but it's just it's a tracheal tumor. Here it is sitting up here on the, see it sitting right here. Young patient, I think she's in her 20s or 30s. I've seen a couple of these at the AFIP. This is, I think, one of the first ones I've seen or shown de novo. They're relatively rare. This is a granular cell tumor, which is kind of a neurogenic tumor. You can get them in the larynx, pretty rare in the trachea. I mean, definitely they're out there, but not definitely a distant, I don't know, 4th or 5th on the, or maybe even 6th on list of tracheal tumors. So, I mean, not much to say beyond that's what it is. I mean, most people I would have said squame, but just because that's so common. But she was a young non-smoker. Would have thought potentially even adenoid cystic, but kind of a weird location for that, but still more common than a granular cell tumor.
What do you see those like more distally in the trachea, or does it tend to be
The
higher
ones
up
I've
like
seen
that?
have been more I mean, honestly, I think I've seen 4 or 5 from the archives, and yeah, I mean, I've seen them up this high. I've seen them down low. They've been sent in from the larynx. I'm not sure like where their propensity is to be in the trachea itself. I don't know if anyone has more experience with them, but this is more of a question. I mean, so here's this patient, right? Has this thing sitting here, large fatty mass, vasculature interspersed, kind of drapes over the kind of very asymmetric. You can see it here, extending around the SVC and IVC, or around the SVC and azygos. And at what point do you go from something like mediastinal lipomatosis to, I mean, there's a couple strands of soft tissue in here, a few strands. We are wondering, could this be a thymolipoma? But there's not a lot of, most thymolipomas I have are much bigger, but there are plenty of that are this size. It's extending into the middle and posterior mediastinum. Initially when I looked at it, I was thinking, oh, it's going to be a thymolipoma, which are so darn rare. But now I'm looking at it more. I think it's just robust mediastinal lipomatosis. What do other people think? Or how do you, because usually mediastinal lipomatosis is, to me, when I see it, it's usually more symmetric. This one is very asymmetric. But I don't know.
I guess I would have thought liposarc just because of the middle mediastinum, like enveloping the azygos and the SVC. I don't know.
Yeah, we have a study 2 years prior. It's unchanged.
Oh.
I think I would not go with lipomatosis. It's too asymmetrical.
Yeah.
It's just, lipomatosis is basically everywhere there's fat, and this one is really trying to be the final thing. So I would go with lipoma or thymolipoma, but you know, I'm sort of thinking this is lipoma or low-grade liposarc.
Yeah. God, the liposarcs, I've seen a lot of liposarcs. I mean, this just doesn't have, I mean, there's a little wisp of soft tissue, but nothing really.
Yeah, and I think the stability too is a good argument.
Yeah.
So I mean, but low-grade liposarcs can stick there forever and never do anything.
Right.
And I think we read it as, you know, probably a thymolipoma. I think that's how we officially read it. But the more I look at it, the more I'm just not convinced of the diagnosis.
Right.
Would you guys do anything? I mean, the last thing I want this guy to have his chest cracked open and this thing pulled out that's been there for so many years and stable.
Would a PET scan help, do you think?
I don't think so. I mean, personally, I just don't think so.
It doesn't look as if there's that much soft tissue.
Yeah, exactly.
To light up.
Okay, well, I'm glad I'm not the only one who couldn't really, you know, because I saw this, I'm presuming is some thymic tissue down here, this hazy stuff anterior pericardium, but who knows? Well, hopefully the patient won't come back in a couple of years with a massive liposarcoma. Yeah. That would be.
No.
Yeah, I don't know. I mean, I guess I would say follow it on a year or every other year basis, maybe just to see.
Yeah, maybe I'll addend it and tell him to do that.
Shit, I don't know.
Follow up into.
Given the soft tissue components that you thought was thymic tissue, that might, if that lit up on a PET scan, I think you'd be more of an activist about this.
Okay.
Well, I guess that begs one other question. I think PET's a good idea. Is there any chance it could be a hybrinoma, which could be metabolically active on PET?
Geez, I didn't even think of that. I don't
know. I mean, I remember
just a massive ball. I mean, just a massive ball of brown fat.
Yeah, I mean, I've only seen one that I think in the media time. I think that Brent Little showed me that because it was metabolically active, but it wasn't pure fat like that. I don't know.
Okay, yeah. So I think that would, if this were a hybrinoma, it will light up diffusely. If it's just that the soft tissue component that looks thymic, then I think that would distinguish it from a hybrinoma.
Yeah.
Okay. Seth, are you talking? I've lost audio.
Can't hear you, Seth.
I think I'm going to take. Let's see. I'm going to take the screen, I think, and see. And then I'll give it back to him. Hey, Seth, we couldn't hear you. I don't know if we can hear you now, but I'll try again and give it back to you.
I messaged him on the chat.
He may not see the window, though.
Give it back to him and see. I'll text him. Oh yeah, he at least acknowledged it in the chat, so maybe he'll figure it out.
Travis, you want to show some cases?
Yep.
Then we can go.
Yeah, I'm gonna show some. I'm gonna take over here. All right. Well, Do you see my screen yet?
Yes.
All right. So here's one I've had some time to dig up some cases that I've been saving over the last couple months, and this is a patient who was referred to us for transplant, and the lungs certainly look busy in the lower lobes, and maybe you can tease out some parallel airways or some tram tracking or even some airways that you see on FOSS that are dilated and thickened, and upper lobes look maybe like there's a little bit of paucity of vasculature too. But we had a CT at the time of the radiograph, and so this patient has severe emphysema, you can see in the upper lobes. But it's not just in the upper lobes, because as you scroll down into the lower lobes, you see arguably the emphysema gets more severe. And I remember many years ago on this conference that I think it was David that showed the first case similar to this, but it was only the bronchiectasis that the patient has. This patient has lower lobe predominant bronchiectasis, plus they have what looks like panlobular emphysema. And so this is a case of alpha-1 antitrypsin. And I don't remember seeing one that had both. I remember, David, yours had almost exclusively bronchiectasis or more severe bronchiectasis, correct? Or some of the ones you've shown?
Yes.
So this is a patient that has both manifestations in the same scan. And I had always thought it was just two different phenotypes, but I guess not. I don't know. Have you seen one that was combined like this, that was this severe?
I don't remember right off whether I have.
But yeah, it's just, I think, just a reminder, as David first taught me, that bronchiectasis certainly can be a manifestation of alpha-1. And when you have lower lung predominant bronchiectasis, it's something to think about. And the pulmonologist will always, or should, check an alpha-1 level. But this is the first one I've seen that was a combination of both, the emphysema and the bronchiectasis. All right, this one's a quickie, and I know one of the UCSF fellows and future faculty, Shrav Shadar, is on here, and there's a case from UCSF a few years ago I showed. You can see and he may have seen it, but you can see it looks like there's a wire or something that looks metallic in the azygos vein, and it's very linear and long. But I think one of the clues here is you see there's a little bit, paravertebral vein as well. And the case that we had from a few years ago that I showed, it was actually in the pulmonary artery and had been mistaken for an embolized wire fragment when in fact it was just embolized methyl methacrylate. But sometimes when it extrudes out of the vessels and casts itself in a vein, then it can look very linear and wire-like in this case. So, not too exciting, and more just make sure to recognize that it's not a metallic foreign body, but rather just a cement foreign body that can have that kind of cast-like appearance there. So it wasn't mistaken in this case, but that's what it was here.
What is it in the cement? They must put something in the cement to make it dense, because methyl methacrylate itself is not all that dense.
Yeah, I don't know.
So they put iodine or barium in it or something like that?
I don't know. I don't know what it's mixed with, but all the vertebroplasties and kyphoplasties always show up radiopaque. So yeah, I don't know. Maybe I can look that up later, or somebody else can look it up. But that's a good question.
Travis, I'm back. I'm sorry.
Oh no, that's okay. Here, I'll let you. Let me show a couple, and then I'll get back to you here. This is one, Seth, in particular, and I know Nick is on here too, for people that do a lot of coronary. This is something we didn't do at UCSF, but I'm becoming a big fan of here at Duke. So this is a patient, and you can see their coronaries have a lot of soft tissue, or stuff surrounding them. And it's not, in most places, it isn't necessarily causing severe stenosis, at least not yet. You may have some mild luminal irregularities and mild narrowing in the LAD. I think in the right coronary, you might argue it's moderate in the 50% stenosis range, but it goes fairly long length along all of the coronaries. And you'll also notice that they have slightly unusual morphology of their left atrium, and they have median sternotomy wires. So this patient has had a heart transplant a couple of years ago. And this was one of the first cases of cardiac allograft vasculopathy I'd seen on CT. And so are you guys doing coronaries for early detection of cardiac allograft vasculopathy? Anyone on here?
No. We should be, but we don't. We're doing MRs.
Yeah, this is, because it was the gold standard, it was always considered cath, but when you have the early, more like intimal proliferation, and you get all the soft tissue surrounding the coronaries, that there's some more recent data showing that CT can be useful in the first few years, because this is one of the most significant causes of morbidity and mortality early on. And so it makes sense that we would be able to see this earlier than cath, if since they're only seeing the luminal narrowing component of it. So we're doing this on I think a lot of our heart transplant patients now, doing routine screening. And I don't know the frequency. It may be every year or every 2 years.
We're doing stress MR on microvascular issues, but I would rather do CT, honestly.
Because we can do heart flow on this too.
Yeah.
So, and some of this is,
yeah,
mild and moderate there.
Peter, there you go.
Here's another one. This is a patient. This is also a heart transplant patient. And you can see in some areas they have some, wall thickening and stenosis. They'd actually had a couple of stents placed because I guess I don't have the earlier one. I thought they'd had an earlier study that showed that they had allograft vasculopathy, and so they had stented in a few areas, but you can see other areas there's some soft tissue thickening. So these patients do get accelerated atherosclerotic disease as well, but this is a separate autoimmune process that results in the intimal proliferation. But I don't know, just the first case I think was a better example. I'll have to find the pre-intervention CT for this patient.
Is it inflammation? What is it?
Yeah, it's autoimmune. Like it's like a form of rejection, essentially. I think. I pulled up one of the more recent papers in AJR. If anybody else has more experience with it, feel free to chime in. I can find it.
Kind of question along the same lines is that do they just increase the immunosuppression to deal with that, or what's the management?
That's a good question. I don't know. I've like I said, I've only seen this a few times now and wasn't really familiar with it before I'd gotten here. I'll look that up, but I'll let Seth go. Like in that one case, once it gets to significant luminal narrowing, then you obviously treat it. But yeah, let's see. I'm going to make you the presenter here.
Okay.
I'll pull up one of the other papers that talks a little bit more about it.
I was saying before my audio died on that freaking thing is that this is not that, I don't know, it's not that interesting case, but it kind of is. This is a CF patient, a 40-year-old with CF, and this is just an inspiration and expiration scan obtained right, subsequently, one after the other. What was amazing to me was the amount of transient plugging. I guess it's not really plugging, it's just the thickened airways becoming opposed during expiration, because the bronchiectatic airways are kind of somewhat floppy, and the amount of you can see here in the anterior left upper lobe, this area was completely open on inspiration, and all these airways collapse and plug up on expiration, and kind of made me think about, we always think about the the small airway. Obviously we think about the large airway morphology in relation to the bronchiectasis, but of course the small airway injury in relation to the mosaicism. But it was just like, look at this here, just completely plugged up on expiration. It was just very interesting to realize the amount of dynamic collapse they have of these bronchiectatic airways and how it must, so promote to their symptomatology. And I just hadn't really seen this much before, this much just transient collapse and occlusion of the larger airways. So nothing really, I guess, rare, groundbreaking, just an interesting observation I don't think I've seen in the past. I mean, even the lower lobes, these airways were patent before, were big, and now they're collapsed down. So it just kind of made me think about that it's more than what we see on the single image that we often, because we don't acquire functional imaging, that we often miss out on a lot of the other factors that may lead to patient symptoms. Anyways, I kind of thought that was kind of interesting. This is a case we had yesterday, and I don't know what it is, but it's been confirmed at cath. She went to cath last night. So this is a young patient, 40-year-old female, who's been having a few months of very severe chest pain on exertion. And just get it into plane. I think you can start to see that the left main, but it's not just the left main. So here, I mean, you can see the left main coming out and it's just diminutive, absolutely tiny, and then becomes large again, as not large, normal in size. But you see this throughout. So first I was thinking, okay, SCAD, but then it's throughout a lot of the vessels on the left sided circulation. RCAs is actually completely normal. Even the circ, you can see here, is very, very narrow. There's the areas where it opens and closes, gets larger. Anyways, similar findings, the LAD, RCA was completely normal. Now, interestingly, for either SCAD, atherosclerotic disease, or vasculitis, there's really not, I mean, all those cases where you see SCAD or vasculitis or atherosclerotic disease, there's something abnormal surrounding the vessel. I mean, there's some sort of inflammation either in the wall of the vessel, there's some plaque, there's whatever. SCAD, you obviously, you'll see, if it's like this, you'll either see a thrombosed false lumen, but there was really nothing here. It's just all these areas of very strange narrowing. So, I mean, I gave a standard differential of some sort of vasculitis, although there's absolutely, she also had a CTA. She had a CTA of the chest and pelvis the day before, which was completely normal. There was no evidence of FMD, at least on imaging. And she, I don't know. And then vasculitis and then atherosclerotic disease that wasn't visible. But her, again, she has no family history, risk factors. You can see here, like the LAD just gets, it's just undulating, small, big, small, big. Anyone seen anything like this before? Because struggling to come up with a good unified diagnosis.
I guess was FMD, but I guess there's no evidence of.
Yeah, that's what they're going to do the workup, because that's what I was thinking. Is just, I mean, I guess you can have all normal other vessels and just have it involve the coronaries. And I don't know how good just looking morphologically at the vessels on CT. And this looked narrowed at the ostium. I thought it was, but it actually wasn't on other recons. Okay, well, but nice to know that they cathed her and we weren't crazy, that those findings were real. And I don't even remember what this case is. Oh, there we go. This is, I showed one of these the other day or a couple weeks ago and had no clue what it was, but this is remember I showed a different case where it was like a PAPVR, but also connected to the pulmonary vein. So this is another levoatrial vein here, just found incidentally, as they usually are. Again, we haven't had very good cases recently, so it's about as good as we've had.
Yeah, I don't know what to do with these, because there are case reports of patients having strokes, since it can be, or TIAs. but obviously this patient has a port and probably has bigger issues at this point.
Yeah, it was just found on, I can't remember
Yeah.
what malignancy she had the port for, but yeah, not sure what to do with these. Just kind of mention them and leave it at that. That's all I got today.
Nice. Thanks. All right, let's wait for my screen there. So I did find, this is one of the papers on cardiac allograft vasculopathy. And so they say in here, it's a delayed type hypersensitivity immune response. And so you get the intimal hyperplasia and this concentric luminal narrowing like I was showing. So eventually it narrows the lumen, but before that it can be outside of the lumen, much like calcified plaque can be a lot bigger than what you actually see, or non-calcified plaque when you have positive remodeling.
Because you don't see any necrotic cores here. You don't see like the necrotic core. It's all intimal.
Right.
Do they say that anywhere? I'm curious what the.
Yeah, well, and they're saying this is superimposed on native coronary artery disease. There's a lot of arrowheads here.
Okay.
But yeah, so I think that what they're trying to say is there's, you know, the elastic lamina here, and then a lot of this, I'm guessing.
Well, the internal lamina disappears at some point.
Yeah.
Then you get all this, whatever that gobbledygook is.
Yeah. But and of course, like, yeah, they often do cath with IVUS to see this, but I guess we do some more coronary CTA just as a non-invasive alternative.
Interesting.
All right, so that was those two. The here's one that LVAD patient, and we have a lot of LVAD patients, and here is outflow obstruction. And I've shown a few of these, I remember, and Peter, you may remember one of the cases, like, I think it's when you were a resident that Brent saw. And, you know, originally we would call this thrombus, and I know I've shown cases, but now that I've learned, especially when they're really largely isolated to the bend relief and have more of this smooth margins like this, you know, somebody wanted to call this thrombus, and I said, no, this is probably just debris within the bend relief. So you have a lumen within a lumen, and the bend relief is helping to, you know, prevent this from kinking, and just part of this bend here. This was severe enough. Patient had low flow alarms. They went in. This was all proteinaceous goo or gel that was between the layers of the bend relief, so it's not thrombus. And you know, I don't know. I don't think I've ever seen a case of thrombus involving the LV outflow cannula that I can remember. This is actually that's the old CT. So this had developed over the course of a couple of years. This was 2019, and then they've just gone in and this was after revising it. They were doing an abdomen pelvis for some reason, but you can see that now this bend relief is back to normal. So yeah, I think most of the time people ask, like, how do you tell the difference between thrombus and stuff in the bend relief? And I guess my only answer is I've never seen thrombus in the bend relief, so I just bet it's going to be, you know, eccentric stuff like this. I don't know. If anybody else has a case of like confirmed thrombus, you know, please share. I'll jump to this one since, wait, which one is it? Maybe it's this one. So this was another case. Now this is a patient with an LVAD who presented with a stroke. And in this case, it isn't the outflow cannula, but it is the native aortic root that has a ton of thrombus in it. And of course, if an LVAD is functioning properly, the aortic valve shouldn't be opening because the blood is, the left ventricle doesn't work. The blood is going out through the pump and through the cannula, the outflow cannula, into the aorta. And in this case, you know, for this patient, they increased his anticoagulation. Fortunately, his coronaries aren't totally occluded at this point, but you can imagine especially that right coronary artery looks mighty close. But he had presented with a TIA, and this was all just thrombus here. And honestly, I don't know how much of this is acute. Some of it, like, maybe this is just calcification of his native valve here, but I wonder how much of this is chronic thrombus. But hopefully, it'll lyse. But we haven't seen a follow up on him yet. But this is the largest amount of thrombus I've ever seen collect at the aortic valve.
So Travis, shouldn't this happen to everybody because of the hemodynamics that you mentioned, where the aortic valve is not opening and the cannula is dumping in distal to this, so there's really no circulation and stagnation at this point, right?
Well, yeah, I don't know. I can't explain it. I mean, I think that probably you're getting some retrograde flow to fill the coronary arteries. Think of patients with congenital heart disease that have had a Damas K stanzel or something, where you're piggybacking the aorta onto the PA for the single ventricle circulation. But yeah, I don't know. And these patients usually are at a pretty high INR anyway. Yeah, it's pretty infrequent. I think we see only a handful of these. And you're right, David. I don't know.
I think with some of the new LVADs, the heart rate 3, I think the valves are opening.
Are they? I mean, that would make sense to maintain any bit of function you can in the left ventricle, to get some forward flow.
Yeah, but I don't think these are. I mean, I haven't seen a clot like that from before. So it's interesting.
Yeah. Here, I do have 40 images on this patient. I can show you. Let's see. Did that actually load? It's a big data set. You can see how much this valve is actually moving. Yeah, because David, it's a very good question. But it is, hopefully it's just that their level of anticoagulation prevents it in most cases, but I don't know a great answer for you. All right, let's see. We can just do a quick cine through this and see if there's much motion or movement at all. We get. Yeah, that left ventricle is not doing much. Let's see if we can get to the aortic valve and see if it's actually. I don't expect there to be much motion here. Yeah, I mean, you wouldn't be able to tell anyway, but yeah, I don't know what his EF is, but it looks like it's probably less than 10%. It's barely moving at all.
Yeah. Can I perseverate on your bend relief case?
Yeah.
A little bit. So the bend relief is an outer tubing, and there's an inner tubing that's actually conducting the blood.
Correct.
So there are two walls involved.
Correct.
Is that right?
Yes.
And some material can evidently get through the inner material and fill that space, and then protein, coagulates there. Is that right?
Yep.
It's
exactly
permeable or something like that?
Yeah, I don't know. I don't know how it gets there, but we see this time and again.
Okay.
Yeah. There's I'll try and pull it up and email it to you. There was a nice, just an image from an abstract, I think, that had a gross photo of it. That was when they took it out. But yeah, in my experience, at least, it's much more common than thrombus. And I think it's important to recognize. I think most surgeons have now seen it enough that they recognize it, because upping their anticoagulation is not going to help in these cases.
Okay, thank you.
Hey Travis, that more focal filling defect there at the end, is that also the same thing?
They said it was all bend relief. That
Okay.
like right at the end here.
Yeah, that's interesting, because can you see? Okay, because I usually think of that the bend relief stuff is just along the walls, but I've never seen it like that. That's interesting. Okay.
Well, it is along the walls. Here, I'll do an MPR.
Yeah, the other stuff along the walls.
Yeah, So you can see
There's definitely
just
thickening along the walls, but that additional thing at the end is
right.
a little
It's
strange.
kind of, and you can see how it. I mean, look, it's like pinching in
Yeah.
on 3 sides here. Yeah, so that's what you're getting is, yeah. So all of it really connects like that,
Right.
Peter.
Yeah, that's a good view for it. Yeah.
Yeah, and you can see here on this view. And it kind of often has this kind of oblique or wave-like configuration.
Thanks.
Yeah, this is one where you have to know, or don't have to, but it's nice to know the history. And this is a patient who was an MVC, had chest pain, apparently hit their chest on the steering wheel, because this is one of those ones that, is easy to overlook. But when you know that they hurt anteriorly and you have a lateral view, you can see the sternum looks a little wonky, and then you've got this extra little opacity back here. Could be a little bit of hematoma, but certainly this looks like an abnormal configuration. You suspect that there's a sternal fracture. So that was not called, and then the patient got discharged from the ED. We're seeing in follow-up at their clinician's office. It's, I guess, a few days. See when this was. This was 6-7 days afterwards, and now they did an external radiograph, which we rarely do, but now you can see clearly there's a step off and a sternal body fracture. This guy still had pain, and he had some degree of instability. This was a few days later, and again, how easy these can be to overlook on axial images, especially if there's not acute blood or inflammation surrounding it. But this was here. This is why it's always important to look at the sternum in a different plane, like this sagittal, because they did actually repair this guy. That they put a reconstruction plate in his sternum to fix that. So yeah, it's one of those ones that in the end, no harm done, but it would have been nice if it had been observed the first time, I think. I was having a discussion with a colleague elsewhere. Are people still seeing median sternotomy wires, or are a lot of places going to reconstruction plates like this? Because my colleague in Tennessee seemed to indicate that they were doing a lot more reconstruction or sternal plates rather than sternotomy wires.
We're moving in that direction too. For the transverse sternotomy that you do with bilateral lung transplant.
They're doing the transverse sternotomy even for other indications?
A plate rather than just cerclage wires.
Yeah.
For the transverse sternotomy, but I think for the median sternotomy, the longitudinal cut, we're still doing sternal wires mostly.
Okay.
Travis, can I show a case real
Do
quick,
it.
just for a compendium
Let me
comparison for the
yeah, here you go.
So I showed this many years ago, but this was a HeartMate 2, which aren't used anymore, but they may still be out there. And this is probably this is the inflow cannula. This is probably that gelatinous goo. But here, look at the outflow cannula. This has a different bend relief because it's a HeartMate 2. But here, this is all, and this was thrombus because this stuff embolized all over her brain and gave her massive strokes everywhere.
Wow.
So you can see here, and there were just strokes up here all over the place. And then here, she eventually died from her strokes. But you can see there's just all these different territories were occluded from the thrombus in the outflow.
Nice. Well, not nice for the patient, but yeah, that's a good image. So that extends a lot further than just that. Yeah, that stuff's going.
Yeah, the bend relief is here. There's a bigger bend relief on the inflow, and the outflow has a short relief here with the heart. But the clot really starts distal to that bend relief area.
Yeah, that's a good one, right? Yeah. Well, good. Thanks for showing that. Like I said, yeah, I haven't seen it. Like most of what we see is just the the other stuff. So that's really good to see.
Yeah. All right. I'll let you grab it back.
All right. Thanks.
Yeah, you can see the outflow is fine here, and then all of a sudden it's just clogged.
Oops.
Yeah, no, it's good.
Sorry, I stole it from you.
Oh, I was done. Yeah, thanks.
All right. This is a patient that came into the ED, and young patient has substance use disorder. Apparently, at this time had been retching quite a bit, and way too much linear stuff in the mediastinum. Obviously, this is pneumomediastinum. Nice little, at least partial continuous diaphragm sign here along the inferior margin of the heart. Now, and this question comes up over and over, as it did in this case. And you know, when you see pneumomediastinum, especially if the history is vomiting, you know, how can you be confident that it's not Borhop syndrome and that it's alveolar rupture or Macklin phenomenon? In this case, you know, this guy looks like he probably aspirated some. He's got some junk in the larger airways, and we see some air along the bronchovascular bundles in the left lung. And I know I've referenced this before. There's a paper in JTI that some of my colleagues at Mallinckrodt did 10 years ago or so. And really, you know, unless you see a lot of fluid in the mediastinum or you see pleural effusions or a lot of inflammation, it's almost never esophageal. You know, because invariably, I know any of the residents on here at night, you're always asked to do a swallow study or, you know, or a CT esophagram. It was interesting in this case, this guy had his esophagus looks thickened, like he has esophagitis, but we, you know, didn't see anything convincing. But a day or two later, he's intubated. I don't know why he was intubated, but a day or two later, he was septic. You can see that he still doesn't have effusions, and his pneumomediastinum has almost completely resolved. But because of his sepsis, they actually did an endoscopy, and they also did a right-sided thoracoscopic surgery, expecting his esophagus to be perfed, and it wasn't. It was inflamed. There was periesophageal or paraesophageal inflammation, but there was no frank rupture. So I think that, you know, the rule still holds true in this case. But they were, you know, apparently he was doing poorly, so they decided to go in and look to make sure. Because we thought, you know, I thought this was not going to be esophageal rupture, and then was just curious once they actually had gone in, but they did not find any sort of perforation. So I don't know. Do you guys use that as a rule when you're trying to differentiate them? Or do you just defer to the swallow study in all cases?
We do a lot of CT esophagograms for this, although it's not as anywhere near good. And then if the CT esophagram is positive, we do it. If it's negative, then if we're still concerned, they go to direct esophagram. But
yeah, we started doing a lot of CT esophograms. So what was the cause of the pneumomediastinum on that one, Travis?
Presumably Macklin phenomenon.
Oh.
He was retching, you know, which just because he's vomiting or retching, you know, doesn't mean he can't increase his intrathoracic pressure and rupture an alveolus as well. So this is a quick one. I know I've shown a few of these. More hypervascular thing in the anterior mediastinum. I have to be honest, I think if I would see this in isolation, I don't know what I'd do with it. I mean, these anterior mediastinal things, this one's maybe a little bit bigger, but you know, oftentimes we see little nodes and you don't know what to do with it. It's a little higher than thymus, but in this case, we had a history and this patient had hyperparathyroidism and was able to go digging in the chart and see this. And so the CT was done because they astutely observed this little area of increased uptake in the mediastinum. So this did turn out to be an ectopic parathyroid adenoma that was in the anterior mediastinum, but I don't know. This is one of those areas where incidental things are frustrating because oftentimes you just have small nodes there, but maybe because this is hypervascular, and I know Seth has talked about that more, just adenomas being commonly hypervascular, maybe
Yeah, that
make
one's
sure to follow it. But
has such a high, I mean, it's brighter than the aorta, or almost as bright as the aorta.
yeah,
I mean, that's, you know, I would definitely think that small hypervascular tumor.
yeah, rather than just a little node. That's a good point. I mean, maybe if you just saw it as normal, typical soft tissue attenuation of other nodes, then maybe be less inclined to be aggressive with it.
Yeah. No, but I was defending someone who was in a, legal case that had one of those that was called a lymph node, and then it grew into a thymic carcinoma. And, and whatever. I mean, it was just one of those like that, where you would look at it and people called a node, and they called it a node, and that was it. And,
Yeah, I guess if I have doubt, then I usually I usually will just say like 6-month follow-up. I don't remember. I think it was addressed in the incidental paper that Reggie Munden co-authored, but I can't remember. So this is quite an interesting case. This is a young woman who's a drug user, and you can see she's already had a median sternotomy and everything. All of this was done elsewhere. So she had tricuspid endocarditis, and she had septic emboli. The septic emboli resulted in a mycotic aneurysm or pseudoaneurysm of her left lower lobe pulmonary artery, which I don't know at the time, the rationale, but they had attempted to cover that with a stent, which you can see clearly didn't seal off this aneurysm here. But also impressively, what she's left with, and Seth, maybe you've seen this from infected emboli, but she has chronic thromboembolic pulmonary hypertension now. Her RV's dilated and thickened. Her her pulmonary artery pressures were pretty high. She has some areas you can see occluded vessels, and this looks like they tried to do some sort of plug here. But on the left side, it's mostly that. But on the right side, you can see her right lower lobe pulmonary artery is just completely out, and she has big bronchioles in the right lower lobe. And I think the other clue here is you have slow return of venous blood back to the left atrium. And this was like a year before, but she got referred to us because we have a surgeon who I think trained in San Diego who does some degree or some volume of thromboendarterectomy now and is establishing an East Coast CTEF center. But they needed to repair the tricuspid valve anyway, or replace it. And so the plan was to do as much as possible, replace that, see if the stent could be removed and this artery repaired, and then do a thromboendarterectomy. They ended up successfully replacing the valve, and he was able to get a plane and peel out, do an endarterectomy on the right side, improve her pressure significantly, but the stent was significantly incorporated, so they just they left that alone. But this is the first one I remember from like septic emboli being a candidate for thromboendarterectomy. Have you seen a lot of those at UCSD?
A few, and they do not like doing surgery on them because the results are nowhere near as good, because the infected clot causes a lot more scarring than just bland thrombus, and there's a lot higher chance for perforation and just tearing of the vessels. So they actually really don't like doing those here. Like they will, but they quote a much higher mortality rate, and in some instances they won't even touch it. So but I think we had a case many years ago, 3, 4, 5 years ago, where someone came in and had classic septic emboli and underwent thromboendarterectomy and got better pressures, but not dramatically better. And
Okay. Yeah, and I think they had exhausted all of their options in her case, and it was pretty proximal disease on the right. She did well. She was just discharged a couple weeks ago, so
that's good.
Yeah, exactly. All right, this one came in a few weeks ago, and really busy radiograph. And you can see the hyla look pretty full here. And when you zoom in, it does look like you can see some airways that look like they're just thickened and dilated up here. And then you wonder, are these dilated airways, or are they just cavities, as well as a few nodules? But it looks like it's a lot of central disease. Yeah, and this was an outside study. So unfortunately, I don't know why, the technique at a lot of outside places around here is to do 5 millimeter axial, but then do like 1.25 or 2.5 millimeter sagittal and coronal images like this. These things drive me nuts, but I can try and MPR the sagittal, and I think it'll actually give us a better axial image than the axial alone. But you can see that when I was first looking through this, I saw this stuff. That's not very good. We'll just do the 5 millimeters and live with it. When I first saw these, I saw a couple nodules and saw a couple look like little cavities, and noticed this trachea and how just totally irregular this mucosa looked from the sternal notch down. The entire trachea just looks really inflamed and nasty. And then got to this area and noticed that a lot of these are just areas of bronchiectasis with a lot of inflammation and wall thickening. This looks like something acute going on. If I hadn't seen the trachea, and this amount of inflammation, the first thing I was wondering was maybe some weird distribution of papillomatosis. But then you see all this inflammation, and this doesn't look like papillomas. It looks like more active inflammation. Then got to wondering, but this lady was sick. She had been treated for sinusitis for a few weeks, and you don't even need to look past the thumbnails, but you can see she's got pansinusitis that's severe and ended up intubated. So we were kind of stuck. I didn't know if this was some weird infection, but the first thought was going to be some sort of vasculitis or GPA, especially with the sinusitis. And it turned out she was intubated, then developed renal failure, and rheumatology saw her, and her C-ANCA and her PR3 both did come back positive. So this is presumptively GPA. The interesting thing about this one, and Seth, when you were showing that case of the coronary arteries, she spiked her troponin a few days into her hospitalization, and they went to cath, and she had severe 3-vessel disease. And this, again, you can't really see anything on here. It doesn't look like there's a lot of external wall thickening, but it was like mid to distal vessels, and I haven't seen it, but the description was that she just had diffuse narrowing in the mid to distal vessels, and they eventually attributed it to the GPA. They couldn't do anything about it, and I found a few case reports of coronary involvement reported in GPA, but again, it's like a rare manifestation of a rare disease. So I don't know if it's true or not, but have you seen coronary involvement with GPA before? I've seen aortic vasculitis, or has anyone seen this kind of look in the airways with GPA?
Not that bad. I've seen the trachea and more focal bronchiectasis and kind of stuff, but not like that. Impressive.
Yeah, it was kind of like when I looked at this and put everything together, it's like the differential kind of stopped. It started and stopped with vasculitis, like GPA. She wasn't really acting effective, and she had, didn't have a productive cough, and this would be weird anyway. So yeah, this is presumably GPA based on the serology, and she's not doing well. And then we'll end with one more. I just thought this was a fun case. This is a patient a fun physiologic case. Let's see. This is a few years ago. They have severe emphysema. This is not alpha-1 antitrypsin, but they do have a lot of lower lobe disease. And in fact, the right lower lobe in particular, considerable amount of emphysema. And this was done outside with contrast, but pulmonary veins here look good. And the reason I show this one, because this patient, I think this is just a fun physiologic case, that they did a PE study after this patient had these endobronchial valves. So they have endobronchial valves only in the right lower lobe, as you can see here. So they have soup seg plus 4 basilar segments. and notice that we're pretty early in our timing, but all of the pulmonary veins opacify except for the right lower lobe one. And there's no PE here. And somebody was saying, well, could this be thrombus? And it's like, I've never seen thrombus in isolation within a pulmonary vein without some other explanation. I think the better explanation here is just that this is just hypoxemic vasoconstriction and slow flow. Now, we didn't get a venous phase, but I think this is just smoke that can be explained by the fact that these airways are plugged and trying to shut off this lobe. So I don't know. What do you think?
Yeah, 100% agree.
Yeah, it's kind of cool.
Yeah.
So
I think if you put it on lung windows, you'd probably be hard to find. Actually, the vessels are all super attenuated on that side.
Yeah. Relative to the left, you're right. So I just thought it was fun because it's a good physiologic explanation, and sometimes people want 100% proof, but I think this is good enough. There's so all right. Well, it's 4 o'clock here, so we will stop. But thanks everybody, and see you next week.
Take care.
See ya.